am Dr. Shashidhar and this is my team. Today we are going to operate a minimally invasive endovenous laser ablation procedure on a young fellow who is suffering an venous insufficiency due to great saphenous vein, varicose veins. This is an minimally invasive done under ultrasound guidance as a daycare procedure under local anesthesia. This under ultrasound guidance we gain access to great saphenous vein. This is how we place an introduction sheet to the great saphenous vein, and ultrasound guidance we put a small needle inside the vein. This procedure EVLT is done under local anesthesia as a daycare procedure. We gain access to the great saphenous vein through a small needle which is pricked using ultrasound guidance. So we gain access, we get back blood, a small wire is passed over the great saphenous vein. This is a 6 French radial sheath. Which is passed over the guide wire. So we have gained access to the great saphenous vein and we confirm that this sheath is inside the vein by ultrasound guidance. This is our new 1940 Neo laser machine. This is the latest advancement in the laser technology. The mechanism of this laser machine which burns the great saphenous vein is different. So the advantage of this Neo laser is the post-op pain is so negligible that the patient can get back to their all the sports activity, regular activities by next day itself. And one more advantage what they claim is the patient need not wear the stockings probably after a week of the procedure. This is the new 1940 laser fiber which is connected to the laser machine, and we have kept a continuous 6 watt running for varicose vein. We have kept it in a continuous mode. This has got a light in the tip, so we can see where exactly is the fiber inside the vein. We are passing the laser fiber through the GSV, through the 6 French sheath. As you can see, the laser fiber we can track along the GSV and it goes all the way all along to the great saphenous vein junction. Saphenofemoral junction which we have focused, and we are passing the laser fiber which you can see the laser fiber also moving inside the great saphenous vein, and we have kept the laser fiber about 2 centimeter from the saphenofemoral junction. We can see that the fiber is moving and we have kept about 2 centimeter distal to saphenofemoral junction. And in this present scenario, the vein is very big, so it needs to be given tumescent. So we are injecting a tumescent normal saline next to that of the vein so that to compress the vein, so that the approximation of laser fiber with the vein will be good and the effect of the laser is also good. We can see the fiber inside the great saphenous vein. Since it is quite big, a good tumescent is also equally important. You can see the needle coming across the around the great saphenous vein so that the tumescent is given, so that the vein collapses and the effect of the laser will be good. The tumescent is given all along the vein. You can see that the needle inside the saphenous sheath, saline being injected and the vein being collapsed, and it is hugged to the laser fiber. In the ultrasound, you can see that the laser is being activated, and you can see the laser is being pulled slowly in a continuous mode, and we can see that the vein is being closed with that laser thermal energy. Here we can see the laser fiber which is in the great saphenous vein, which is getting ablated, and it is slowly pulled in a continuous fashion all along the GSV, and it is again confirmed by sonography the laser being ablated inside the great saphenous vein. And ultrasound guidance all along the great saphenous vein inside the great saphenous sheath. We give this tumescent so that the vein gets collapsed, and the effect of the laser burning to the vein will be very good. Here you can see the laser fiber is being pulled from great saphenous vein from saphenofemoral junction up to just below the knee joint. We don't burn usually the leg vein because the saphenous nerve and the sural nerve injuries are quite common, and below the knee joint we usually prefer only sclerotherapy or hook phlebectomies. Now the great saphenous vein is ablated almost up to the knee length, and this next the short saphenous vein will be burnt. Now you can see the short saphenous nerve being cannulated and the fiber being passed, and we can see that the laser fiber goes up to the saphenofemoral junction. Now after burning the great saphenous vein, the short saphenous vein will be burnt. The laser fiber is passed to the short saphenous vein, and we can see the laser fiber going up to the saphenopopliteal junction, and we confirm this junction under ultrasound guidance. And then we will start burning. For the lateral perforators, we do sclerotherapy. A small butterfly needle is inserted into the vein, and cetrol is given all along the vein, so that we can confirm on the ultrasound also that it gets obliterated. Now the procedure is done. We have given sclerotherapy for all the perforators, and we just remove this sheath off, and the procedure is done. We just apply the compression stockings along with crepe bandage for 24 hours. After that, 1 month for compression stockings, and then the patient can discontinue the stockings also. Now after removing the sheath, a waterproof dressing has been applied, so that it will be comfortable for patient to take bath. Now once the procedure is done, we apply stockings, we apply compression crepe bandage for 48 hours. After that, the patient goes home only with stockings. Now this compression crepe bandage is also applied for 48 hours. After that, only stockings is adequate. Now initially for 48 hours, we allow it to be there continuous throughout the day, but after 48 hours, it's only during the daytime the stockings is adequate in this procedure. Thanks, and now the procedure is complete, and after 2 hours we will make the patient walk, and this completes the procedure, and he will go home in the after 4 to 5 hours. And thanks everybody for supporting. Thanks anesthetist, and thanking you the team for successfully completing the procedure. Thank you.